Hi, good morning, good afternoon, and good evening to all of you. Thank you so much for attending this session on transformative learning approach to foster intra-country and intra-country collaboration. I am Dr. Rajat Garg from India, moderator for this session. We are really excited to see you here and to hear out our speakers to share their insights. So I'm looking forward to hear from them. If you have any questions, you can just put them on the chat box. Please do not click on share audio and video, as if the panelists will want, they will ask you to come. It might disturb the panelists. So if we want you, we will ask you to come in the panel and ask your questions. If you want panelist-wise questions, then you can put that on chat. Like if you want any particular question to be asked, to be answered by Carolina, then you can put in chat, and we will be taking the questions after that. We have got elite group of panelists today. Carolina De Navarro from WHO, Marta Jackie-Globo from WHO, and Vitamir Kovanovic, who is from Center from Change and Complexity in Learning. So now I would like to hand over it to Vitamir Kovanovic for this presentation. Over to you. I think we are not able to hear you. Are you on mute?
Yeah, of course. Let me.
Yeah.
Okay.
Yeah, please.
Thank you so much for the introduction, and thank you everyone for joining. So my name is Vitamir Kovanovic. I'm a senior lecturer from Center for Change and Complexity in Learning and University of South Australia. So today I'm going to tell you a bit more about the work we did with Geneva Learning Foundation on this COVID-19 Hub, which is a new initiative and that started in collaboration with my research center, and how we analyze the data, what kind of insights we got from this new model of training. So just quickly, so I'm from this center for change and complexity learning, which really in my research group, what we are doing, we're looking at how we can use connection between human and artificial cognition to really have some impact on society. So really looking for practical application and impact of digital technologies for all kinds of domains, and heavily involved in learning analytics research.
Sorry to interrupt you. Yeah, just pardon me to interrupt you, but there are some comments in the chat box that the participants are not able to hear you. So maybe there are some connectivity issues. I would advise, I think you have already switched off your camera so that to increase the bandwidth for audio.
Yeah, I'm gonna turn off my camera now. Yeah, I turned it off now.
Yeah, and I think you can be a bit closer to the mic to increase the sound quality.
Yep. So and is it better now?
Yeah, it's much better. Thank you.
Okay. So really, so the key thing that we are doing is really this idea of learning analytics. And what is it really? That's really use of the data and analytics to help people to learn better, whatever of the environment. So primarily, of course, happening in the formal education at universities, high school, and so on, but also for improvement of professional training, informal learning, continuing professional development, and so on. And really what we try to do is to use all of this available digital data to understand learning and really improve how people learn, to make certain changes, to help them in certain way, to personalize, and so on. Now, how typically these things look, just to, one more slide, just to explain you roughly what is it all about. So we have on one side, for example, a classroom or students online, doesn't matter. They produce certain data, right? They use certain tools, and then we capture this data in certain databases. The data is already there in many cases because, for example, data on Zoom usage, that data is already being stored. Then what we do, we use this data and analyze it in certain ways to provide feedback, typically feedback to instructors or maybe school administrators, and also feedback to students themselves. So for example, student might say, hey, you haven't been studying this week enough, what's happening? Do you need some help? And so on. And so that's kind of the idea, to really analyze all of this data and to make certain help, to help both students and instructors to make certain action, whether to adjust the way they learn or help learners learn better. Now, typically how it's done is through certain form of a dashboard. For example, we will have, this is one of the demo dashboards by one of the companies, and kind of many of them look very similarly. So what we did for COVID-19 Peer Hub. So I'm just going to go quickly, what is it about and how our work fit there and what kind of insights we got from there. So it was really, the Peer Hub was a network of immunization professionals around the world, several thousands of them. And really what they are really doing there is sharing knowledge, sharing their ideas, practices around fighting COVID-19. And interesting part about COVID-19 Peer Hub is that it runs across many different platforms. So for example, they will be using Zoom for certain sessions, then they will be using another platform called Vazoku for ideas, then they will be using another platform called Kajabi and so on, and their Telegram and all kinds of different platforms. So it's not really your typical online course. It's not like that, of course. It's more than that, and it runs across different platforms. And what it really enables from a practical side is to get some insight into the state of COVID-19, whether about what challenges people face, how they are overcoming them, or more recently about, vaccine introduction, for example. And the interesting part about Peer Hub is that aside from being this place where people get together for sharing ideas and knowledge, there are also these different exercises. So but this time, so far, there have been two exercises. The first one was development of the action plan. And then the second exercise was about vaccine hesitancy. So I'm going to show you the main part of our analysis, which was around COVID-19 action plan development, which happened a few months ago, finished in September. And so how the different activities, those exercises look like. So they're all certain Zoom sessions. So there is a global general assembly once per week. Then there are daily sessions of, lightning session, they're called, where really people discuss different ideas with experts such as Francois Gasse and others. And then there are also daily technical support sessions where people ask if they have any technical problems. Now, aside from having those synchronous sessions on Zoom, there are also a key activities with sharing of ideas and practices. So people who were involved in the exercise, they also generated certain ideas they're thinking about doing, or whether something they're currently doing around certain themes. So for example, one of the themes was about vaccination campaigns. The other was about sustaining demand for vaccination, and so on. After this phase of idea generation, then scholars were involved in development of their action plans. And that consisted of two phases: of development of the initial action plan draft that's been then peer graded by other scholars in the exercise, and then eventual final action plan. And so if you look at this in a graphical way, so you have these three parts. So first part, this generation of ideas and sharing of the existing practices. Then we have this phase where people adopt and use their ideas to develop their projects, and eventually they finalize their project after peer feedback. So in total, we had Peer Hub, this first exercise that started was from during 6 weeks in earlier last year. there have been 4,700 people who applied, and about 3,800 were accepted into the program. So from this number, about slightly over 2,000 people engage in certain form of activity. So whether they attended Zoom sessions, submitted their ideas, they drafted their project, and so on. Keep in mind that not everybody was really looking to do all of these activities. Everybody was participating to their own capabilities and needs. And eventually, 706 people submitted their final project. Now, what we really did with all of this data that's been available and while this program was running, we were really first integrating all of this data and developing visualizations of this data that will enable us to get some insight. First of all, what's happening in form of learning, and also to get insights about COVID-19. From technical side, I guess that's less important, but it's been developed on Amazon AWS platform and use certain technology called RShiny. Not super important, but just in case you want to know. And really what we try to achieve is to gain some useful insights, to see what is the power of these learning networks and what kind of knowledge we can gain. So I'm just going to run you through some of the things. So as typically done in these learning analytics systems, so we developed a dashboard, as I said, to integrate all of this data. And that dashboard enabled us to pick specific exercise and then to drill down on a country level. So for example, this was part of the dashboard showing how much our participants are they involved in COVID-19 response. So then we see that most of them said yes. And then we see for 3 different lines represent people who applied for the program, who got accepted, and who got certified. So eventually we see that higher percentage of people who got eventually the certificate, they were involved in COVID-19 response. And then this is the overall for all participants in the program. However, we can drill down for every specific country, and then we can see different, we can go to different parts of the application and see what ideas they shared, what are their action plan, those projects, how they attended Zoom, and so on, different surveys they did, and so on. Now, looking at this first exercise, so we see that the majority of participants were from Ministry of Health staff. So primarily subnational level staff, and the other big group was national staff. So in total, they accounted about 60%, almost 60% of participants. Then there are other staff, NGO staff, staff from WHO, UNICEF, there were students as well, and others. In terms of the age, gender, and their background, so there've been about 25% of female, 75% male. And in terms of the background, people, about 75% were people who were new to Geneva Learning Foundation online programs. About 25% of people had some previous experience. Then, in terms of age, roughly 39 years was the average age of participants. And they come mostly from subnational levels. So about 3/4 were from subnational level. There were also national and people from health facility level. Now, another part, when they applied for the program, they provided information about, okay, who they are, what they are doing, and so on. So, and majority of them, about slightly more than 30% of people, were immunization staff trying to maintain vaccination services. And the other big group was other health professionals who are involved in COVID-19 response. So, and then we can see, first of all, who are our participants, where they are coming from. And then in their enrollment application, they answer the question what they see as a major challenge to COVID-19. And overall, the major challenge, by far the biggest one, was the caregivers being reluctant to come to facilities for immunization because of fear of COVID-19. But then interesting things happen when you look at the country level analysis. For example, this might be overall biggest challenge, but for example, if you look at some different countries, we see different things coming up as the major challenges. And then you can see other ones. So another two big frequent challenges were lack of confidence in vaccination by the community and inadequate communication and community engagement, and others as well. Now, so once they're enrolled and we get all of this information, we really use as insights of a current state at the start of the program. Then at the end, during the program, participants are contributing, as I said before, producing certain ideas and practices, and they belong to one of these 7 big categories, if you want. So demand was about increasing the demand for vaccination, health worker safety, about challenges around safe procedures, about catch-up planning, maintaining vaccination campaigns, about VPD outbreaks, about human resources and supply chain. And the majority of them were obviously about maintaining the demand for vaccination. That was clearly the biggest type of ideas people shared. And then, interesting, from the way people interact with these ideas, we can see, for example, which ideas have been seen the most, which have been commented the most, meaning they provoke certain activity by the other participants and so on. So then we have, for example, idea about providing certain photos of facilities to share caregivers and so on. That idea has been had 35 comments, so definitely it resonated with other participants. And by that way, and all the other ways people interacted with the ideas, we can see, some that might be quite, hidden gems, and some ideas that might not necessarily be obvious to everybody, and that almost comes from the data itself. And now, very, very interesting is that these ideas are not just being, okay, yeah, come write your idea and, comment to each other. People use these ideas for development of their action plans. And then while they were writing action plan, at the end, they provided almost a list of references, whether to certain government materials, but also other ideas. And that enabled us to see the level of collaboration that's happening. So we really see that in COVID-19 Peer Hub, we have really a global network of people that collaborated. So all of these lines represent citations between certain project from one country and idea from another country. For example, we see certain lines, majority obviously being sub-Saharan Africa, but other parts, Southeast Asia, Latin America, USA, and other part, Europe as well, and so on. So we really see that people are building up on the ideas that really are not from their local context. So this really shows that the power of the whole network to foster collaboration that's really would be very, very challenging to develop in any other way, especially during the pandemic time, when travel is non-existent. And then another thing, we can look at where people seek those ideas. So on the left side, you see the level of the author of the project, of these action plan projects. And on the right side, you see ideas. So then we see that the people who, authors who are on the national level, their projects didn't just cite ideas on the national level. They also heavily cited ideas from the sub-national level, district level, and even on a health facility level. And that's really true for all the levels. So we can see even that the health facility action plans, they've been citing ideas from all over the place, right? So we see really that there is this sharing across levels of a system, and that's really critical if we want to promote this better adoption of best practices, and especially for things that are so rapidly changing, such as COVID-19 situation. And a similar thing, because we know for every participant every scholar, where they work, and they provided that information as part of the enrollment, we can see how the different organizations. So for example, we see that consultants from WHO, UNICEF, they've been primarily drawing up from subnational ideas on a subnational level. We also see that pretty much the same applies to NGO stuff, and obviously every level was citing their own level. So we see heavily that national MOH staff were obviously citing the ideas from the same group of people and so on. But then we see really across different levels, which is quite interesting and exciting. And then because of the peer evaluation, we see there was a peer evaluation phase where initial drafts have been peer graded. We really see that that can be used to surface some good ideas and action plans that been evaluated by three other scholar as being really good. So for example, these are just summaries. Obviously there is the actual PDF file of the action plan, but they've been we have a way of capturing this very, very quickly. And now what we really learn from all of this data crunching and combining and so on. So first of all, Peer Hub really is giving us a great opportunity to see what is happening with regards to COVID-19, whether we talk about the global level across the whole network, or maybe per, I don't know, WHO regions of the world, or World Bank region of the world, or per specific country, right? We can look at how is the situation in Cameroon different from DRC and so on. And then because we have captured the levels of different scholars, we can see how the different parts of the system experience COVID-19. So how somebody on a health facility level is experiencing this pandemic rather than somebody working on a national, Ministry of Health and a national level, and so on. And that really gives us the way of getting what are the key issues that they face in their everyday work. Another important thing that we saw from all of this data analysis is really that this community is very, very highly active with a lot of potential. So there have been a lot of action going on, whether it's attendance to different sessions, writing of ideas, providing thousands of comments and action plans, peer feedbacks, and so on. And interestingly, good ideas get picked up by the community. So by having this common place where to share different ideas and practices, they get picked up, and we see that. We can see which ideas have been cited the most, commented the most, and so on. And all of this shows us that there is a really strong cross-pollination between scholars that would really not interact in other ways. And that really gives us a way to really reimagine this professional development. So just prepackaging materials is not enough. And then we see that, I'm come from higher education research, that same thing is happening in academia with the push to lifelong learning. Just prepackaging something is not going to work. Especially if we have something such as COVID-19, which is super high, fast-moving target, which requires massive collaboration on unseen scale so far. And really, the typical top-down approach is fine, but it's not agile enough and not contextualized enough. And we saw some of those comments being raised by Katie O'Brien in the plenary talk when she mentioned that we really need to have some way of making the system more agile and better train those systems because we cannot provide training materials for every possible situation. And the same thing is in my personal, professional work. So yeah, that will be my presentation. I would like to hear your comments and your questions and any feedback and so
on. Thank you for a very excellent and detailed presentation, Vitomir. And I could see the excellent data analysis as well as the brilliant data presentation that you did, and it was really great. We've got, I think, one comment from Pamela, how this can relate to implementation of the actual plans.
Vito, I see many comments in the chat, many questions, so I don't know how we go about that.
Yeah.
Yeah, there are two
Maybe
ways.
I can read one. Pamela Leon asks how the information about the plans relates to the implementation of the actual plans. That's one. And then Elizabeth Colway asks how many countries were represented in the first Peer Hub exercise? And
about 90 something. I forgot off the top of my mind, but 90 something countries. So.
Mm-hmm. And yes, there were many countries with 1 or 2 representatives. So she asked also, how can learning be derived from countries with little representation?
Well, that's really the benefit of a network such as this. If you try to organize, a training session with 2 people, that would not be super exciting nor productive. But here you're part of. It doesn't really matter that much where you are. I mean, there are time zone challenges, obviously, for certain groups, such as, I don't know, Southeast Asia and so on. But other than that, you can participate, connect with other people, and so on. Definitely, obviously, there are context-specific things, and people in the bigger countries, they've been developing their own country groups. When they have, besides all of this I showed, they will have their own support group when they will be doing things together. For smaller countries, they will be either joining some other group or participating in those big sessions and so on.
Thank you.
Yes.
I don't know what's happening. Rajat, can you hear us?
Yeah, I can hear you. I would request Vitomil to please stop your screen share. And I would request Carolina to then, after that, I think you can start your...
We don't hear you, Rajat.
See, can you hear me now? Am I audible?
I hear you. I hear you well.
Yeah.
Oh, that's strange.
Okay, then I will put my comments on the chat. Can you hear me, Carolina? Okay.
I think Carolina has lost her.
Can you convey this message? Okay. Can you convey this message, Vitomir, that she can screen share and start with the presentation, because I think she can listen. She can hear you.
Yes, Carolina, can you just start your presentation? If you cannot hear Roger, just start your presentation now.
So Vita, you have to stop sharing your screen. It looks like you're still sharing.
Oh, okay.
Carolina.
Okay, that's good to know.
All right. All right. Rajat, while we wait for Carolina to come back, I know that obviously you were one of the leaders in the. Okay, here's Carolina. So let me. Do you want to say a word about when you hear Vitamir's presentation as a data and learning scientist? How does that connect with your experience? And I hope, Carolina, you can hear us. You can hear us now.
Yeah. So, I think firstly, I would like to acknowledge that the data presentation and visualization was brilliant in the last presentation by Vitomir. And secondly, I would like to say that definitely the cross-learning has helped a lot, especially in challenging times of COVID, where health workers or even the program managers, they were a bit confused that how to address those issues. But definitely some innovation somewhere happening in some part of the country, reaching to another part of the world through this peer hub, that was great, and it was a great learning. And I think that millions of children must have been vaccinated and must have received their due doses because of this cross-learning activity. And I think we should do more of this, and more of engagement of program managers should be there, and with some tech literacy, I think health workers can also connect. So that is my take on this.
Rajat, before we go to Carolina, I just see a question that is actually from Omolara Adeyemi. She said the greatest challenge at lower levels is the network internet access. So how was this overcome? And Rajat, if you can turn down your speaker a little bit, because it sounds like we're getting feedback from your microphone, that would be most appreciated. All right, yeah. That's a really good question. So when we started doing these courses on immunization in 2016, we had maybe 3% of people participating from health facilities. And then it was really, some people obviously are excluded because of access issues, and that is true to this day. However, what's startling is the pace at which this is changing. And so what we found is that we're now at, I think you saw in the Teach to Reach conference, it's 30% or between 20 and 30 from health facilities. What we found also is that the secret is motivation. So if people find their own intrinsic motivation for participating, we started seeing in courses people who would drive 400 kilometers from the field to the closest location where they could get decent internet access just to connect to a discussion group. And that you cannot buy that. You cannot prescribe it. It really comes through years of concerted effort and mutual peer support, and people seeing how that actually benefits them. We have seen participants become national EPI managers. We have seen participants go on to lead vaccination coverage surveys. We have seen remarkable change, and people. That's why that's where you get the motivation. I hope I haven't been too long in my answer.
I think that was great, Rita.
All right, Rajat, you want to give the floor to Carolina?
Yeah, definitely. I would request Caroline to please share your slides and go ahead with the presentation.
So you're muted, of course.
Okay, let me try to figure out how to do that.
So next to the microphone icon is what looks like a little screen.
There it is. And I don't want to share my entire screen. I just want to share. Basically, in this part of the session, I just want to highlight a few things that were very useful for us at the WHO level and learnings that came. So I don't want to bore you with all the information, but basically, I don't know if you can see properly. Early on, we identified in May last year that there were really important disruptions to immunization programs, and some on the immunization side of things, the offer of services was the low availability of personal protective equipment, low availability of health workers, travel restrictions, and then also important disruptions in demand for immunization. So really, the peer hub has been great to answer some of or as a platforms where people can discuss the issues that they were seeing for their immunization program, because everybody understands that you still need to vaccinate the children. So this is just some data of how much the decline in number of doses month by month compared to 2019 was happening in the different regions. And that was, of course, of a big concern to everyone. This is just some countries where, the different months, the different declines. A few countries, again, in the entire world. Also declines in vaccine preventable disease surveillance, which is of concern because we may be later in detecting outbreaks. A lot of problems with labs to do testing for vaccine preventable diseases. And then another thing that was really a problem is that the cost of running immunization programs became higher because you, of course, have to increase your investment in hand washing stations, in masks, in support for crowd control, etc. Having smaller sessions. Campaigns were dramatically postponed, which of course results in accumulation of people. So from the WHO side, there were some products there, and you're going to have this information to try and implement campaigns in this context, really to do a cost-benefit analysis and then make your decisions. And you can see now that a lot of campaigns are now finally being implemented. And some big campaigns were implemented, and you have here some interventions that were made. Just very shortly, and this is probably my second to last slide, is just to let you know that because in the peer hub and everywhere we have identified that some children have missed their vaccinations, WHO has put out guidance on how to catch them up via through routine system, expanding the ages and making sure that children, even if they are past 12 months of age or 2 years of age, it's better to vaccinate late than never. And you have all the guidance here for the different vaccines, whether you're going to do intensifications in outreach, etc. And also just to say that from different parts of the world, there are many new strategies, and this is a slide from PAHO, where countries are vaccinating in different places. And again, in the peer hub, you saw this and you implemented some of these new strategies. And I think I'm going to stop here, just leaving you this slide up with what I wanted to share. So if you're interested and planning how you're going to bring up children to up to date and women and other people, you have some updates. Thank you.
Thank you for the great presentation and enlightening us with great information and knowledge. And I think that was very well done, and that was very crisp. I think I can see few comments in the chat box. Like one of the comment was from Puran Sharma, that was regarding availability of different type of vaccines. Like in India, there are 2 vaccines. One is in the phase 3 trial, and the other vaccine is being rolled out, that is the Covishield. So maybe there may be vaccine hesitancy. The actual comment is that as vaccine hesitancy is high in India due to the rushing of use of vaccines without the phase 3 trial efficacy and safety reports. In this background, 2 types of vaccines are being used. Don't you think that it would help overcome vaccine hesitancy if only one type of vaccine is used in a particular state? This would help the field level health workers overcome the hesitancy. So would you like to have any take on that? Because I think there might be a situation in many countries where such problem may arise, because usually for any particular disease, there is only one vaccine which is given, for which there is a particular dose, particular route, and health workers know about that. But now there may be a case where for the same disease, there may be more than one type of vaccine, and which might be administered from a different route and different route of administration at different sites. So how to address the hesitancy in case of that?
Let's give some reaction to that. We are in a very, very exceptional situation. We had never been able to develop vaccines this fast. And of course, we are in a situation that is less than ideal. Ideally, we would have had much more time to prepare to introduce a new vaccine, to prepare our material, to train people, etc. Now, the vaccine around that's available is not enough for the entire world. And you have seen delays and still countries that have not started vaccinating. So even though, not having or having more than one vaccine is problematic, I think we have to adapt, and we have to be creative and use the material that's already available on how to deal with hesitancy, more than hesitancies, people sometimes are in that continuum of being indecisive about it, and really make vaccination become the norm and help people facilitate things for them to get the vaccine. I think in the peer hub, a lot has been done on hesitancy and increasing demand. And I think the more people get vaccinated, the more it becomes the norm to be vaccinated, and others will join. So yeah, I mean, and health workers are always more hesitant sometimes for influenza, for example. But I think that now that people are getting vaccinated, it's going to be people are going to be more enthusiastic about it when they see that others are doing that, and that's being seen already in the world where things are increasing.
Thank you for the response. There is another comment from on the chat that is the issue of vaccine hesitancy. They need to be taken on board by engaging them during the sensitization phase, giving them true facts on the importance of immunization and its benefit in the long run. So, would you like to give any insights?
Very quickly, I think one thing are the facts, and that's really important for people to understand, but you have to reach people's concerns and emotions. People are hesitant because they are afraid usually, not because they are philosophically wrong or anything. They are concerned about their health. So you have to interact with your users in a human connection as well. And there are some techniques for that, etc. And really to be on the listening side, not dismissing people's fears and concerns, but really responding compassionately and with the information, but also answering their questions. And I think that's really useful to have information sheets where you answer frequently asked questions, etc. And the more people get vaccinated, again, people feel better that is becoming the norm and feel more comfortable.
Thank you. That is very good to hear, because the health workers are usually in the habit of getting the FAQs, and those FAQs will address the frequently asked questions, and most of the queries will be addressed. So that was very good. Now another question from Reda, that in the past it was sufficient to ask the MOH what is the situation for an epidemic. With COVID, IVV decided to launch the Pulse survey. Why collect subnational data now? What were the challenges in collecting enough data to build a useful picture to inform WHO's work?
Again, this is a very extraordinary situation. We have not had a pandemic of this magnitude, maybe ever, and a world that is so interconnected. So what's happening now here in Geneva, affects what's happening in Chile immediately, or almost immediately. So really, we needed to have a sense of how much the disruption was in the immunization program, and our mechanisms to collect data from member states usually are, for immunization particularly, are annual and very set, and they take time to make sure that we're not overburdening countries with data requests and with clear uses. Of course, we could not have foreseen that we would need to know so quickly what was the situation in the field. And that was important for us to understand quickly to respond. What were the main problems that people were seeing in the field? So having this pulse surveys that we did in April and I think it was early June last year, and what the Geneva Learning Foundation did, help us understand two big things. One, that there was a huge need from the field to better understand the infection control and prevention and control measures for vaccinating safely. So continue to vaccinate children and other regular sessions, how to do that in this context and do it safely. So that led to a seminar, and the people here from the Boost, from Saving, were instrumental to do that, for example. And then on the demand side, it was very shocking to see how much hesitancy at the time happened, and different things happening in different parts of the world. In one part of the world, for example, there were rumors about vaccines being tested and these strange things. So that helped us also to do a better reply and response. And I would say also the catch-up, we're very concerned that we are going to have immunity gaps. So some children who should have been vaccinated in 2020 may have missed the vaccination for, there was no transportation, people were afraid to go, million reasons, right? You could not do things normally. So with really the need now is to bring people up to speed and to monitor how that's going, to understand if we're going to have immunity gaps that may risk outbreaks, and we should try to prevent them before they happen. Over.
Yeah, thank you for your response. Definitely, it is a very tricky situation, and the vaccine hesitancy nowadays is even higher in the health workers and even doctors because of the vaccine being developed in such a short period of time. So there are definitely some apprehensions, and they can be addressed only through communication. There is another question, I think that is a very valid question that from Bashir, that with regard to COVID-19 vaccine, which type of vaccines is more effective? So
I cannot really give you a straight answer with that because the data it's coming and coming, and I would say at this point, really in your own countries, you have the information that the national regulatory authorities have used to make the decisions to introduce, and all vaccines have pros and cons. I really would say keep checking our website for WHO because all the information is there. At the moment, all vaccines that are being used are effective and safe. I see in the chat also people talking about some of the effects. And of course, there is a lot of work to monitor adverse events following immunization, and anything that happens that is temporarily related to the vaccine to really investigate to see if there is a causal relation or not, because this vaccine targets people that are more likely to die of natural causes, right? Older adults, for example. And there are going to be more coincidences. But each country has a committee to work on assessing causality and really working there, and also to respond to crisis. And it's so from your end, I think one of the most important things is to make sure that the protocols are followed to report things, to report the vaccines administered, so we can really understand the effectiveness once we do vaccine effectiveness studies or with what's happening in the field. And second, report any reaction, anything that might be related to the vaccine for investigation, for causality assessment. So I think that's the key. It's to keep up to date with the information that's coming, and then report, and try to follow the protocols set in your country.
Yeah, definitely, that's very right. You said rightly, increasing the AEFI surveillance reporting is the key to address that. And I think with health workers taking the vaccination first in countries like India, I think the trust of community will build up because they will see that, okay, doctors have taken them themselves. So definitely this vaccine is going to be safe. Another, you can say, question from Christopher. There is so much misinformation on the internet. Why can't the vaccine developers join the efforts to counter this misinformation? So although a lot has already been done regarding the Facebook pages, the Twitter, but I would like you to definitely take this up.
So people who are hesitant and who are anti-vaxxer make a lot of noise. And sometimes, you know how you get whatever Facebook gives you and you hear more about what you already think about. So you are in these echo chambers of people who think like you get those posts, etc. So there is a lot of work already to try to minimize that and in a way avoid that some rumors or some people that make a lot of noise that really get out of that. And sometimes not responding, it's a better strategy than trying to go online, because it's kind of fueling the fire, where really it's important for us as health workers to stick up to our message, to keep listening, to understand what people's concerns are, to really not respond directly, but really if people are concerned that some conspiracy theory, just put the facts there and, you know, not start the blaming game, but really this compassion and understanding of where people are coming from. They are coming from a place of fear usually, and go from there to give your message and try to assuage those to counter those fears and to provide the information and the connection again to people that you yourself are doing it, getting vaccinated, and you are doing it because you believe in science and you are trying to do the best for the population.
Thank you again for answering it so well. As Dr. Anita Bhargav had put in chat beautifully, that colossal challenges in such a dynamic situation. So definitely it I think tells us about that. Now I think probably the last question for this session from Timothy. What's the position on the adequacy of the COVID-19 vaccine, considering it to be given 2 doses, 2 weeks in between, and it's to be rolled out globally?
So basically you have to administer vaccines how they were licensed, particularly in your country. So the different manufacturers have different periods between those one and those two, 21 days, 28 days. And there are some exceptions that some countries have been doing. I think in for the global level, you cannot really go for just one thing. I can refer you to recommendations from our strategic advisory group, which basically state follow the guidance of how it was licensed, each vaccine. But in some countries, you may adjust that given the circumstances. However, I think the most important thing is that if the vaccine requires 2 doses, you must ensure that people get their second dose. So the monitoring system needs to be really good. So if I go to your hospital to get vaccinated and I'm not in the list, you have to put me in the list to make sure that I go back. And if I haven't gone back when I need my second dose, try to call me or text me or something so I can get my second dose. Otherwise, we're going to have many people half protected, let's say, and that's not ideal.
Very well said, Carolina. As Christopher has put up in the chat that thank you for the answer and no need to get into fights with deniers online. So before we close, any closing remarks from your side?
I'm going to put in the chat the link to our page where the advice is from our strategic advisory group. So I just put it there. And I would say keep checking because the situation is evolving. And we never before had so many things happening so rapidly. So the dynamic information being generated, produced, analyzed, synthesized, and try to be made into recommendations. So you are users of information, but also producers of information. And we need to keep it that way to be a two-way communication. Thank you.
Yeah, you are very right. This is a very dynamic, unique situation where there's a lot of information that is coming, being analyzed, and that lot of data being generated. So any closing remarks from you, Vitomir?
Well, yeah, thanks for the invitation, and I hope really that what we presented here shows you some of the insights we got from COVID, from Peer Hub. Really, that's from my end, and yeah, I think Carolina provides a really good summary of situation. So yeah.
So that actually sums up. Yeah. I would like to thank you all for the great presentation, Vitomir and Carolina. You enlightened us with great information and knowledge. I would like to thank the audience also for their active participation and joining the session. Thank you so much. It was all very great. Thank you.
Good luck, everyone, and keep it up.